All right. I think that I'm just gonna go ahead and get started. So hi everybody. I think hopefully as other people come in, I see already that there's a question. So what I was going to ask, which is awesome, I'm gonna ask if people have questions to just list the questions in the Q&A. And then once I'm kind of done with my kind of talk, then I'll go through the Q&A questions if that sounds good. So I'm going to go ahead and get started. I have some slides prepared, so I'm going to share my screen. And hopefully everybody can see this. Okay, good, great. So thank you all for joining tonight's seminar. So my name is Jenna Friedenthal, and I am a reproductive endocrinologist and infertility specialist here, double board certified in OBGYN and REI. I'm here at RMA of New York. So as a reproductive and infertility specialist, I specialize in the diagnosis and management of reproductive disorders, mainly infertility, but also fertility preservation like egg or embryo freezing. For a little background on me, I completed my undergraduate education at Yale University. I then completed my medical degree at the Albert Einstein College of Medicine, where I received a distinction in research. I then completed my residency in OBGYN at New York University, and then my subspecialty training in reproductive endocrinology and infertility here at the Icahn School of Medicine at Mount Sinai in RMA of New York, where I was invited to stay on as faculty. And that is how I am here today. So I am really excited to talk to you about all things fertility, infertility, fertility preservation. So if it's okay, everybody, I think a good place to start is to first talk about what it takes to make a baby, what to expect at your first visit with an REI like me, and then the diagnostic testing that we do, an overview of treatment options that are available, and finally, info on fertility preservation, like I say, egg or embryo freezing. But I'll make sure that I can leave plenty of time for questions. So let's get into it. So what does it take to make a baby? Really, you need four basic ingredients. Number one, you need to have a uterus that is functionally normal, that can house and sustain a pregnancy. Number two, you need fallopian tubes that are open and without any disease. So those is the fallopian tubes here, because that's actually where fertilization happens if you're not using something like IVF, as in the fallopian tubes. Number three, you need sperm of sufficient quality and quantity to fertilize an egg. And number four, you need to have ovaries that are ovulating in a regular, predictable way, a healthy, genetically normal egg. So to get into it with a little bit more detail, let's break down each piece here. And so there are any number of uterine anomalies that can be associated with infertility. And here we see in the left is like a normal uterine cavity. On the right, we see a large fibroid that's sitting within the uterine cavity right there. And this type of fibroid we know is associated with infertility and increased risk of miscarriage. But there are other types of structural anomalies too, polyps, uterine septums, uterine scarring. And so the best way to evaluate the uterus is with a transvaginal sonogram, which we often combine with what we call a saline sonohysterography, in which we infuse saline into the uterine cavity while performing ultrasound in order to give us the best view of the inside of the uterus, short of actually looking with a camera, such as in hysteroscopy. In order to now just a little bit more detail with the fallopian tubes, how do we evaluate the fallopian tubes? The gold standard is something called an HSG, which stands for hysterosalpingogram. And essentially, you perform a speculum exam, and a small catheter is actually placed through the cervix, and dye is infused into the uterus through the fallopian tubes, and then x-rays are taken, as you can maybe see here, to show free spillage of the dye. So on the left is a normal HSG, but on the right, you can see that this tube here is blocked, and that there's no contrast that's coming out. What's nice about HSGs is that it can also be helpful in identifying like subtle uterine anomalies as well, because as you can see, the dye flows through the uterus too. So it can pick up what are called filling defects that can be caused by fibroids, polyps, scarring, things like that. So next, the way to evaluate sperm is, as you might expect, with a semen analysis. And we're looking at many aspects of the sample, not just volume, but also concentration of the sperm, the proportion that are morphologically normal, the percent motility, and so on. And then finally, we have the ovaries. And what we really begin thinking about with regard to the ovaries is number one, is the person ovulating? Number two, what is their ovarian reserve or egg quantity? And number three, what can we guess about their egg quality based on their history and their age? So, what we know about eggs is that they are like a box of chocolates in the sense that there are, over time, fewer and fewer chocolates, right? So, quantity goes down with chocolates because we eat them, but eggs because they just degrade. And those that are remaining go bad, right? So, quality and quantity both go down in terms of eggs as we age, as we get older. So focusing on quantity, or what we call the ovarian reserve first, I think it's important to remind everybody of the reality of female reproductive aging. Maximum number of eggs we will ever have is actually before we're even born. So the maximum number is when we're about 20 weeks old, still fetuses in the uterus. At that point, we have about 6 to 7 million eggs. But by the time we're born, we've lost 80% of those eggs, and we're born with about 1 to 2 million eggs. By the time we hit puberty, that number has dropped to about 350,000 eggs, and will only ovulate 4 to 500 of those eggs. So by the time a woman reaches 30, she's lost about 87% of her eggs, and 97% by the time she turns 40. And nothing, not pregnancy, not birth control use, nothing aside from fertility preservation can stop this decline. So how is ovarian reserve assessed? So our two mainstays are what we call the antral follicle count, number one, and serum AMH levels, number two. And so I think, it's a funny thing that we're, seeing these fertility trucks around, at least we used to in New York. And the question was, does AMH predict your natural fertility? Well, the answer is no, it does not actually. And we know this because we've studied women who are trying to get pregnant and looked at their AMH levels to see, is there any predictive power, to say, does their AMH correlate with their odds of getting pregnant? And time again, the answer is no. And it makes sense that the answer is no, because AMH is not a marker of egg quality. It's purely a marker of egg quantity. It is just a hormone that is made by your eggs. So the more eggs you have left, the higher your AMH will be. The fewer eggs left, the lower the AMH will be. But when the time comes that someone is trying to conceive, as long as they are still ovulating, whether they have 100,000 eggs left or 10,000 eggs left, the odds of that egg leading to a baby are the same as anybody else in their age group. And so ovarian reserve is not really a marker of egg quality. So how can we assess egg quality? Unfortunately, the answer is that there really is no good test for egg quality. That being said, the best predictor for egg quality, and by that we really mean the chromosome content of those eggs, is female age. And so this is a figure taken from a study looking at over 15,000 couples that underwent IVF to get pregnant. The reason that they are a good population to study is because with IVF, we can actually screen the embryos via something called PGT, where we take a biopsy of the embryos and send them off for testing so that we actually know which of the embryos are in fact chromosomally normal or not. And so on the x-axis is female age, and then on the y-axis is the proportion of embryos in each age group that are chromosomally abnormal. We call that aneuploid, will not lead to a live birth. And I would ignore this uptick here on the left. When this has been repeated, it's pretty much a flat line and then goes up this way. And so you can see on the one hand, look, it's not like you hit age 35 and this immediately jumps to 100% abnormal, right? That's why we all know women in our 30s that can get pregnant on their own. That being said, I think you can see the slope of this curve starts to change and accelerate more rapidly towards 100% abnormal, honestly, beginning at around like 29, 30 years old, right? So 29, 30, about 25% of your eggs are already abnormal, which sounds like a lot, but that's normal reproductive biology. We're just not that efficient at holding out the high quality eggs. It also means, though, that on the other hand, 75% of a 29-year-old's eggs should be healthy and should lead to a pregnancy. And things change from there, right? So by the time we are, 32, 33, that jumps up to 30% that are abnormal. By the time we're 35, that goes up to 35% are now abnormal. By the time we're 37, about 45% are abnormal. By the time we turn 38, that's about 50%, and so on, such that by the time or 41, 42, 70, 75% or more of a person's eggs are already abnormal and will not lead to a healthy baby. And by that, I mean it would lead to an embryo that either won't implant or would implant and lead to a miscarriage, not consistent with life. And so the takeaway from all of this is that we're born with a finite number of eggs. The number of eggs we actually have available for ovulation and pregnancy is quite low and continues to drop as we age. And in addition, the quality also drops significantly as we age. And there is nothing that we can do to prevent this aging and protect our fertility except for fertility preservation via egg or embryo freezing. So hopefully this makes sense. I know I'm throwing a lot of information at everybody all at once, and I talk quickly, so I'll just, like I say, I'll be here for questions as soon as I'm done. And so the goal is to overcome the inefficiency of human reproduction. And so when we think about treatment versus prevention, talking about treatment of infertility first, that will depend on what your testing reveals, right? But let's assume that all of the testing appears to be normal, which frankly happens for a majority of patients. The fact of the matter is you may still want or need to expedite care by undergoing treatment with an infertility doctor. So what treatment options are available? So there are really two mainstays. The first being superovulation or ovulation induction, combined with either timed intercourse or intrauterine insemination. We call them IUIs for short. And the idea is that we're taking greater control of your cycle such that at least there is more predictability about the timing of when egg and sperm are meeting. And that's not the reason that you're not getting pregnant so far, right? And so oftentimes you're given a medication by mouth the first few days of your period. We, look and see if there's a follicle that looks like it's going to ovulate its egg. And if so, we can trigger ovulation with that injection so that you're going to ovulate 24 to 36 hours later. And from there, depending on the results of, your semen analysis, you either go home and have sex for the next 3 days, knowing that you've exposed yourself to sperm at the right time, or we combine with the insemination where you come in the next day, your partner gives us a sample, we wash it, concentrate it, and then deposit the sperm through a little catheter at the top of the uterus. It's done basically just like a pap smear here in the office. And so when we think about pros and cons of this type of treatment versus IVF, certainly this type of treatment is a more laid back approach to fertility care, right? You don't need that many injections. You're not coming in for that many monitoring appointments. So it's more hands off. Biggest con, number one, is the success rate, which for most age groups with unexplained infertility is about 10 to 12%. The other thing is that it's not doing anything to protect your fertility for your future family building goals if you'd like to have more than one child, right? And so the second mainstay of treatment is in vitro fertilization or IVF. So I think to understand how IVF works, it's important to understand how ovarian stimulation works. And to do that, I think it's actually important to start with a very quick overview of the menstrual cycle, because it is through our understanding of the menstrual cycle that we know how to take advantage of the menstrual cycle for IVF and actually for egg freezing too. So at the beginning of your menstrual cycle, your ovaries release a certain number of follicles into the visible area of the ovary. Now, I use the phrase follicle and eggs interchangeably. Eggs are microscopic, so you can't see them on ultrasound, but you can see follicles, which are the fluid-filled, nutrient-dense homes in which eggs grow. And so we can use them, the follicles, as a surrogate marker for eggs on ultrasound. And so these are ovaries on ultrasound. These are actually my ovaries. Yes, I've done ovarian stimulation. I needed IVF not just for egg freezing, but the stimulation process is exactly the same. So I can speak to what it's like to go through this on a personal level too, if that's helpful. And so those dark circles really are my follicles. And so your ovaries contain a certain number of these follicles here at the beginning of every month. And from there, your brain sends signals to your ovaries via hormones to pick one of these follicles to become the dominant follicle of the month, the winner, so to speak, and all of the other follicles just die off on their own. So that one follicle ovulates its egg, and if sperm are present and the stars align, right, that egg fertilizes and makes its way to your uterus and you become pregnant. If not, that egg also dies off and the whole cycle starts over 2 weeks later. So that's the menstrual cycle. Now, why is it important to know this for fertility preservation or for IVF? So going back to how ovarian stimulation works, right? So with either IVF or egg freezing, all we're doing is giving you more of the hormones that your brain is already making, so that instead of these small follicles dying off on their own with the one big follicle getting chosen for ovulation, they are all growing nice, big, healthy, mature eggs that instead of ovulating, we retrieve at the time of the egg retrieval, and then we either fertilize them if it's IVF or embryo freezing, or we just freeze them unfertilized, as in the case with egg freezing. And so you can see these dark circles are all really big, not just the one. And that's because these ovaries have been stimulated for the purposes of either IVF or embryo free or egg freezing. These again are my ovaries, so I can tell you that they were for IVF was for my purposes, but they would look the same either way. So now with ovarian stimulation, you can see in this middle figure here again, this is a stimulated ovary. And once the ovaries are deemed ready, they undergo an egg retrieval. And so in this middle picture, you can see that white line is the needle entering the ovary. And on the left, I think is a nice graphic of what the egg retrieval looks like. So it's all done via transvaginal ultrasound, the transvaginal sonogram. And it's basically the same, honestly, as a transvaginal ultrasound, except that you're asleep on retrieval day. You've been awake for other ultrasounds before that. And at the end of the ultrasound probe itself, as you can maybe see, there's a tiny needle that is attached to the end of the ultrasound probe that we use with the ultrasound as guidance to make one puncture on the right and one puncture on the left through the vagina, through the vaginal wall. And that is how we aspirate the fluid from the follicles. That is how we retrieve the egg. So everything is done vaginally. Nothing is done abdominally. There's no incisions or cuts. It's just a pinprick on each side of the vagina. That's it. And so then those eggs are, if we're talking about IVF, they're fertilized either via conventional IVF or ICSI, which is intracytoplasmic sperm injection. And then the embryos can be grown to the blastocyst stage and biopsied for the purposes of pre-implantation genetic testing. And I would say a large part of the success rates of IVF are based on our ability to perform that pre-implantation genetic testing. Chromosome, and then which allows us to identify a screened chromosomally normal embryo. At RMA, by utilizing a single screened embryo, the implantation rate is upwards of like 65 to 70%, oftentimes higher than that. And so it really makes a huge difference in the success rates. And certainly PGT can be used for more than just chromosomal copy number evaluation, right? We can use it actually for sex selection. We can use it to identify monogenic disorders, meaning if a couple knows that they are both carriers of cystic fibrosis, we can identify which embryos would be affected so that they never give birth to a child with a lethal disease, can identify embryos that are BRCA positive if one of the partners is BRCA positive so that we're never we can eliminate like a risk of a breast cancer in a future child. It's pretty, in my opinion, amazing technology. And then, going ahead to the embryo transfer, that's where it all culminates, right? In which the embryo is put back into the uterus. And so this is the bladder here. And this is all just looking under ultrasound guidance, belly ultrasound. This is the uterus. This is the white line of the stripe in the middle of the uterus. And you can see there's a little catheter. That white spot there is where the bubble is, where the embryos are deposited at the top of the uterus. So now thinking a little bit more about egg freezing. So the ovarian stimulation is actually identical. The only difference is that the eggs are frozen before fertilization occurs. So they're frozen as unfertilized eggs. So now who should be freezing their eggs? There are lots of indications for this procedure. You can see it here, right? Certainly for patients who have pending chemotherapy, radiation therapy, people who are about to have surgery that may affect their ovarian reserve, like cyst removal, endometriosis, or having their ovaries removed. People who have a known diagnosis that's going to put them at risk for early menopause, like people with Turner syndrome. And of course, people who are planning on delaying their family building for any number of reasons, right? Or if somebody knows that they want to have a large family and they're already potentially in their 30s, such that by the time they're ready for baby number 2 or 3, they're already going to be in their 40s, at which point it's going to be much harder for them to get pregnant because of the reasons we talked about earlier. And so I think this is sort of the one of the last things to kind of go over when we think about egg freezing. Is how many eggs does it take to predict success? And I would say I can never guarantee success because nothing is guaranteed, right? You could have a million eggs frozen with me and I'll never be able to guarantee a baby from it. But this is the best data that's ever been published on the subject. So on the x-axis is the number of mature eggs. And then on the y-axis is the probability of having at least one baby from this process, broken down by the age at which you froze your eggs. So for my patients who are 35 and under, which is a good portion of my practice, I always say if we could get 15 to 20 eggs frozen, that would be great. The reason that I say that is based on this data here, because you can see with 15 eggs frozen gives about an 85% probability of having at least one baby from this process. If we have 20 eggs frozen, it gives a 90% probability. And I would say most patients are pretty comfortable with those odds. Now, it doesn't mean that if you want 2 babies that you need 40 eggs and 3 babies, 60 eggs, right? And certainly we know the younger that you are when you do your egg freezing, the better the odds that from that single set of eggs, you're going to have multiple embryos that are usable and normal. But we just don't have as great sophisticated extrapolated data to be able to say for 3 babies, this is what you need, et cetera. And then I think thinking about just the last thing, eggs versus embryo freezing, it's a very individualized question, right? I think certainly for somebody who is single, where the option is either egg freezing or embryo freezing with donor sperm. Most of my patients like to have the freedom of egg freezing. And thinking in general about egg versus embryo freezing, again, there's a simplicity to egg freezing, and those eggs belong to you and nobody but you, and you can use them whenever, if ever, however you like. Once an egg is fertilized, it cannot be unfertilized, right? So it is committing you to that sperm source for that set of eggs forevermore. The benefits of embryo freezing are, number one, the very slight difference in the thaw survival rate, meaning what proportion of eggs versus embryos survive the thaw when you want to use them. At RMA, our egg thaw survival rate is like 80 to 90%, which is great, but our embryo thaw survival rate is like 98%. So it's certainly higher because embryos are bigger. They're about 60 to 100 cells when we freeze them, so they can survive freezing and thawing better than an egg. And then the other difference with embryo freezing is that you can biopsy and screen embryos so that you know more about what you have in the bank. With egg freezing, we just can't do that. So whether you have, 5, 10, a million eggs frozen with me, we won't know the quality of those eggs until the time comes that you want to use them. And then certainly we thaw them, we fertilize them, we turn them into embryos, and then we can biopsy them and freeze them while we wait for the results. So you can get that data, but oftentimes later, and sometimes having that information up front can help to inform us as to whether or not we need to do another cycle to accumulate enough embryos that a person feels that their fertility is protected, so to speak. So I'm going to stop here and I am going to stop sharing my screen and I'm going to see what questions we have. Okay, so going from the top. So first, I'm interested in knowing about varicoceles and sperm motility and count. My husband had his first appointment. He was told he had a small varicocele. I'm hopeful because this is the cause. Any personal experiences here. So yeah, it's interesting, right? There have been a lot of publications back and forth. What the latest data seems to suggest is that if a varicocele is really small and like not clinically palpable and not causing symptoms, in an otherwise asymptomatic person, it may not be the primary cause of someone's infertility. But if he has abnormalities on the semen analysis, which it sounds like your partner does have, then it may be worth actually intervening with a urologist. So I think it sounds like a good idea to get an ultrasound to kind of get an extent of the size. And then you should touch base with the urologist to see how they feel about ligating the varicocele. There were a couple of questions about cost, just generally speaking. Admittedly, I'm not the best person to ask that question to, just because everybody's insurance plans are so very different, and New York is a protected mandated state, so we are very often able to get some or all of a patient's IVF covered, at least in terms of their medications and things like that. So what I would say is that I have a finance coordinator, we all do, right? And so when you're making a new patient appointment at RMA, you can ask them to look at your insurance and what is covered and what is out of pocket so that you can get a sense of what your out-of-pocket costs would be if you know you're interested in egg freezing, for example, or you know you're interested in IVF or embryo freezing. So they can tell you that even before you make your visit. Okay, when would you decide to do a microdose Lupron flare protocol versus antagonist? Every person is different, and so this question is asking about are different protocols for ovarian stimulation to stimulate the ovaries to make the eggs. And how you pick someone's protocol is a highly individualized approach. It should be a very unique recipe for each patient. I always base it on the patient's age, the patient's underlying medical problems, their ovarian reserve testing, meaning their AMH and FSH and estrogen, and their follicle count too. Generally, I reserve the microdose Lupron flare protocols for my patients with a lower egg count. So with generally like a diminished ovarian reserve, and or are a little bit older where I might want to encourage more of a boost of FSH and LH in the body, which is what Lupron does, to try to encourage more eggs to grow. Now, what happens when you want to use your unfertilized frozen eggs? Does the embryo transfer always successful? And is there any way to prepare if you're thinking about using your eggs? So nothing is 100%, right? So the embryo transfers are not always successful. And every center is different. So you should always ask wherever you are getting your care, like what are their success rates? And they should be able to tell you easily. At RMA, the odds of an embryo sticking and leading to a pregnancy are about 60 to 70%. In terms of any way to prepare, listen, start taking a prenatal vitamin. We always say it's a good idea to have, prenatal vitamin with 400 micrograms of folic acid on board at least a couple of months before a transfer. I think for people who are smokers, stopping smoking, doing your best to cut out alcohol before the transfer is also never a bad idea, so that you're kind of prepared already when the transfer happens to be acting as if you're pregnant. But I would say that's really generally it. I'm kind of a less is more when it comes to supplements and things like that. How does the prep for a transfer compare to the prep of a retrieval? I'd say it's a similar question to what I think I answered. There's not really a lot of prep that's required, to tell you the truth. We're the ones on the back end who are doing all the prep, getting your medication set, making sure you have all your blood work. But I would say a lot of people ask me generally about, lifestyle modifications, diet, exercise changes, things like that. Is supplements. The reality is that there's really not a lot of data to show that any of that has a huge, impact. But for example, the Mediterranean diet is one that comes up both for fertility, for the egg retrieval and for the transfer, right? Listen, it's a healthy diet, right? So I'm never going to tell a patient don't focus on, unsaturated fats and fish and whole unprocessed foods, because that's good for you. And I think anything that is good for you is only going to improve your chances for success. In reality, does it significantly change egg quality or pregnancy rates? It doesn't seem to. And so I always say, this is a stressful process for some people. If you need a cupcake on a Friday night to get you through the day, that's not going to be the thing that changes your outcome. When you do an egg freezing, the egg retrieval, and the needle pricks both sides of the vagina, do those holes repair? Yeah, that's exactly right. It's the same as if you had, when you get a needle prick when you get your blood drawn, right? No one needs to stitch that back up. You just hold some pressure and the body closes that hole itself. It's the same exact thing, just in the vagina instead. If your partner does not have normal sperm shape, can it be fixed? Um, yes and no. So it's not as if an andrologist can come in and like change the shape of the sperm per se. But certainly there's some studies to show that like, cutting out alcohol, stopping smoking, exercising can sometimes to some degree modify abnormal semen parameters. So such that if you did like a repeat semen analysis after those modifications, 2 or 3 months later, you might see normalization of the shape of the sperm. Is obesity or age a worst factor that affects egg quality? For example, 35 overweight, will this give a lower number of quality of eggs? What other people ask me is like, which is more important, BMI, your weight or your age in terms of predicting outcomes? Certainly for the purposes of egg freezing and ovarian stimulation, your age is the number one, is number one far and away. It's the number one predictive tool for success. So I've had patients who have said, should I wait a year and lose weight? I think that answer depends on, again, the individual patient. If somebody is 30, with a beautiful egg count and healthy ovarian reserve that I don't think is going to be likely to be changed drastically in a year, it might make sense for them to lose weight, because there is some data to suggest that obesity can affect egg quality and pregnancy rates. On the other hand, if I have a patient who is 39 or 40, or a patient with already a very low egg count, I am not going to want them to wait a year to try to lose weight, because the count is going to drop off, and the quality is at a point where it's going to drop off. Both will drop off so significantly over that year that those are going to be way more impactful than a potential change in the BMI. Hopefully that makes sense. What vitamins should I take during egg freezing cycle? Again, I'll tell you, I'm a less is more, because supplements and vitamins are not regulated by the FDA. So there is nobody overseeing what is in those vitamins. And if what they're claiming is in them in the quantity that they claim, without additives like arsenic and mercury that were found on a spot check recently. So I really say less is more. That being said, taking vitamin D is never a bad idea, especially if you know you're low. And the one supplement that I would say is something called coenzyme Q10, CoQ10 for short. There's not a lot of great data to show that it improves egg quality, but it's an antioxidant and it seems to be relatively benign. I always say with supplements and vitamins, if you can find a company that says National Science Foundation tested, then at least you know it's third party tested and that there's some third party that's evaluating what is in them to some degree. How does treatment differ if you have irregular periods for egg freezing? Thing that differs is really just figuring out your start date. So I have a lot of women who have irregular periods who want to freeze their eggs, and they have irregular periods because they have an IUD in, so they don't really get regular periods anymore, or they have PCOS, so their ovulation cycles are unpredictable. Generally, what we'll do is we'll kind of pick a rough start date, and I'll bring them in a couple of weeks beforehand to see where they are hormonally in their cycle, and then that can help to predict when we want to actually start them. So it's not too much of a challenge, and otherwise doesn't change the stimulation itself. Does a transfer require shots and/or oral medications leading up to it, like for retrievals? The answer is it can, and it also cannot. So for a transfer, the way it generally starts, if it's a medicated cycle, is that you'll take estrogen. It's just a tiny pill by mouth for about a week and a half. We do an ultrasound. We see if the lining has responded, and if it looks like it's ready, then we start progesterone 5 days before the transfer, and on the 6th day of progesterone, the transfer happens. Progesterone comes either as an oral vaginal combo, meaning an oral pill and a vaginal tab, or an injection. And the success rates are equal for both. The injection is just once a day. So some people like that because it's like a one and done thing. But for my patients who don't like shots, certainly we can use the oral vaginal combination. It's just that it's usually 2 to 3 times a day. So it's a little bit more cumbersome. For people who are on the go, they don't necessarily like that. If you have a low AMH, I think is what I'm at a younger age, are you on the road for early menopause? Potentially, is the answer to that. To be frank, not knowing what your AMH is, what we know is generally for women who have a lower than expected ovarian reserve for their age, they may end up entering in menopause a little bit earlier than their counterparts that have a normal ovarian reserve. How much younger is the part that we don't know. Okay, if the extraction requires the doctor to go through the uterus, does that pose a risk to future pregnancy? So two things. When you're doing the egg retrieval, you're not going through the uterus. So the uterus sits in the middle, the ovaries sit on the sides, inside your belly, inside your lower abdomen. And so the vaginal probe is going through the vagina to the side, so straight to the ovary. So you're not going through the uterus, number one. But number two, sometimes people do have to go through the uterus with the needle if there's like a big fibroid, or if the ovaries are for whatever reason stuck behind the uterus and they can't be moved. The answer is no, that does not pose a risk to future pregnancy. It does not cause uterine scarring because, again, it's a pinprick, right? So it's different than somebody who is making an incision that requires scarring or is scraping the inside of the uterine cavity. None of that is happening. But that being said, 95% of the time, you're not touching the uterus even with an egg retrieval anyway. Okay, what is the success rate for eggs that are not mature and retrieval but mature in a lab? The same. If they make it to maturity, the odds are the same. Who do you order sperm DNA deviant fragmentation on? That's a great question. Generally speaking, it's for people who either have like persistent male, like sperm, abnormal sperm parameters, or for a couple that has experienced recurrent pregnancy loss, sometimes we order the sperm DNA fragmentation as well, in case that can help to enlighten us at all. Okay, we already answered this one. My husband's semen now said low morphology, but everything else was normal. Should I be concerned? If everything else was really good looking and normal, honestly, not too concerned. Because we know that morphology is like the least predictive of the semen parameters in predicting fertility or lack thereof. So of all of the things what you're describing, I wouldn't worry too much. What causes AMH to drastically drop? It's a great question. We honestly don't know the answer. What I will say is that, as I think I've said before, smoking is one of the worst things for egg quantity and dropping your ovarian reserve. But for people who are not smokers, who don't have any like lifestyle risk factors, we think that it's something probably genetic, although there's no magic AMH, gene that we know about. But we think it's just something intrinsically genetic that's causing that particular person to deplete their supply of eggs faster than the average person. What causes a man to produce less sperm than the normal amount? Oh my goodness. I could give a whole talk on that. The answer is that there's lots of different causes, and it all depends on where the roadblock is, so to speak. Is there a literal obstruction, as can be the case with like structural issues in the vas deferens? Is there a hormonal blockade that's preventing as much sperm being made as it needs to be because sperm requires testosterone in order to grow? Is it a genetic issue that there's a mutation that's affecting the amount of sperm? They're all different reasons. And if we saw, something's abnormal, we have a reproductive urologist here at RMA, so we would refer to him and he can help, complete the evaluation. Okay, why RMA in New York versus other fertility centers for egg freezing? That's a great question. I think for me, and there's no right answer to this, so I can only speak to me and my experience, right? And I say this as somebody who not only, is a physician here now, but I did my fellowship training here. I chose to stay here as an attending, although I certainly could have left. I had other options for leaving. And I did my IVF here. My 3.5-year-old, which is hiding, behind the pictures over there, is my IVF baby from here at RMA. I think far and away the most important thing for me, frankly, is the success rates, right? And part of how I was choosing to stay here once I graduated fellowship was that I know I wanted to stay at a center that where they have the best success rates of the country, right? And that's largely dependent, as much as we like to say it's dependent on us as the doctors, and certainly we have a role. The embryology lab is crucial, right? And you're going to want to go to a center that is large and has been doing this for many years because large is the case with anything. The more that you do something, the better that you are at it, right? So embryologists that are doing embryo culture, assisted hatching, biopsying, thawing, a million times a day are really, really proficient at it. And that's why our embryo survival rates are really great. That's why our pregnancy rates are above national average. Because we're a big lab, everyone is really skilled at what they do. You go to a place that has fewer cycles, the embryologists just aren't getting the training that they need to really become proficient, and the pregnancy rates suffer, right? So, you can look up anybody's success rates. There are two websites. There's the CDC, but then there's also the Society for Assisted Reproductive Technology, SART website. That you can use to compare different centers. It's confusing, so I always tell people to scroll down to the bottom and look at the cumulative live birth rate and compare that between centers you're thinking of. And I think that that can help to enlighten you to differences in labs. So I think that number one, the far away, the most important thing is the success rate, right? I think the other thing is, going to a place that's been around for a long time means that you know that they know what they're doing. I think we're a well-oiled machine, right? And so we know how to run a fertility center, dare I say it, and know how to ensure that our patient success rates are the best. And that's why I wanted to stay, right? Because I wanted to be able to genuinely look patients in the eye and know that I'm offering them the best success rates. Because as nice of a doctor as I can be, I'm only as good as my lab. I'm only as good as my weakest link. And so everything needs to be strong, not just me. And that's not to say that there aren't other good centers in New York City too. There certainly are. Can you still do egg freezing if you have fibroids or polyps? Absolutely. Will you get a lower egg quantity? Absolutely not, because the uterus is totally separate from the ovaries, and having fibroids or polyps doesn't change your odds of having nice, healthy eggs. I've had 2 pregnancies that have ended in miscarriage. Oh, I'm so sorry. Would IVF be a good option? How can I just decrease the risk of another miscarriage? First of all, I'm so sorry about that. I think unless you've gone through a miscarriage, it's really like hard to appreciate how horrible that is. So to have to have undergone more than one, I'm sorry that you've experienced that. I think the first thing is to go see a doctor, right? And see if their, fertility specialist can diagnose anything that may be the cause, right? Something structural like septum. If one of you has like a chromosomal issue that can, predispose you at risk for recurrent miscarriage. So going to see a fertility specialist is the first step. Certainly, IVF is not a bad option in the sense that it is the only technology available that can help to identify which embryos are chromosomally healthy, right? And so that can certainly reduce the miscarriage rate. It doesn't bring it down to zero. In most centers, the miscarriage rate is still about 10%. But you compare that to the miscarriage rate in the average population, that's like 25% or more. So it lowers the risk by more than half. How do fibroids affect a full term healthy pregnancy if luckily not encroaching on the uterus? Um, I think maybe what you're trying to say is like if so fibroids can grow. So fibroids are benign muscle growths of the wall of the uterus, and it's a thick muscle of the uterus. So fibroids can grow on the outside, they can grow in the middle, or they can grow on the inside, which is the cavity where the baby grows, right? So if the fibroids are on the outside of the uterus, then yeah, we don't really worry about the impact on fertility. We only really care if it's either fibroid that's growing in the inside of the uterus itself, or if it's a fibroid that's in the middle of the uterus but pushing into the uterine cavity and distorting the shape. If it's not doing that, then it really shouldn't affect, a pregnancy per se. Pros and cons with varicocele. I think that same person that asked the other question about it. Yeah. Um, yeah, it's a great question, and probably a question that's better served for a reproductive urologist. The data largely shows, honestly, it depends on the severity of the semen analysis anomalies. In mild semen analysis abnormalities with a small, non-palpable varicocele, the recommendation is generally not to correct it. But if it's measuring large, or if it's palpable, if it's causing symptoms, or if the semen analysis is severe, then that is when there is more of a tendency to correct it. Is it advisable for men to use pills that are promoted to increase sperm production? I never tell people to go rogue, so no. Don't take supplements because a lot of times, there'll be these like male supplements that say like, oh, improve male vitality, right? And it's actually just like some bioidentical version of testosterone, which actually hinders sperm production because if you're taking testosterone, then your brain shuts off its normal pathway for making its own testosterone and suppresses sperm production. So I would say there are sometimes that men need to take pills to help with sperm production, but that's if they've done hormonal testing with the urologist and there happen to be abnormalities in their hormones that are then being corrected. So, in the absence of abnormal testing, no, I wouldn't advise to take pills that are promoted to increase sperm production. Okay, amazing. So those were all the questions. These were awesome questions. Thank you so much for asking them and for sticking around. Um, I hope that this was helpful. I hope that I didn't talk too quickly. If I did and you want to hear more, you can make an appointment with me. Just call 212-756-5777. Again, I'm Jenna Friedenthal. It was really nice to be here. I hope that this was helpful, and I hope I see some of you as patients.